Thank you to everybody for joining our Type 1 Galactosemia Roundtable discussion. Today, we have a packed agenda. We're going to hear from the President and Vice President of the Galactosemia Foundation. Next, we're going to hear about galactosemia from the medical perspective from two experts in the field. And finally, we're going to hear from 3 families living with galactosemia. So thank you for joining us, and we hope you enjoy the content.
Hi, my name is Nicole Casal, and I am the president of the Galactosemia Foundation. I have a son, Joseph, who has classic galactosemia, and he was diagnosed in 2012.
My name is Brittany Cadzillo, and I am a mom of 2 girls with classic galactosemia, and I also sit on the board of directors for the Galactosemia Foundation.
The foundation, it was started in the year of 1985. So basically there was just a group of mothers and they connected with each other, and just after, discussing what's out there for families, they found that there really wasn't anything. So they created a foundation, and originally we were known as the Parents of Galactosemic Children. So what that involved was just being able to connect with new families. And actually, back then there was not social media. So how were families connecting with each other? It was few and far between. And so there wasn't as much outreach as there is able to be today. Our goal is to connect with families and just give as much support, give education about the disease, about what's available to them, connect them with other families. So we have two goals, and that's our one, is just to be able to connect with families and bring awareness. So primarily it's that educational piece. So when you get that diagnosis, it's such a shock for families because it's something that you most likely haven't heard about. So just being able to give them as much information on that and be able to connect them with families, because you most likely haven't been able to connect with someone who is going through exactly the same thing that you have. So, there are different disorders out there, similar stories, but being able to connect with somebody who was in your shoes and knows, what is the path that your child may be taking in the future. And then our other goal is to help bring on research on the disorder. So with that, we try to get doctors interested in galactosemia. We provide funding for different research projects. And those are 2 of the big things that we do at the foundation. Our conference we hold every 2 years to give families the opportunity to meet with other families and also meet with the doctors and the researchers that are currently involved with galactosemia.
So the Galactosemia Foundation is a group of volunteers that are parents, they are family members. Right now we have someone who has galactosemia that's serving on our board, and we each have our own little niche. Like, I have been outreach coordinator. We have Scott, who's been doing fundraising for a long time. And sometimes we switch roles, but ultimately what we are doing is anything that we see in our community that they need as far as outreach or research projects that doctors bring to us that they want to do to find out more about galactosemia. We get to meet together, we talk about those things, we plan the conference. So just really anything that the foundation believes would be beneficial to our community, we get together, talk about those things, and find a way to implement them. So I believe that galactosemia is very deserving of a treatment. It is very difficult to explain that there is a dietary restriction for someone with classic galactosemia. However, even if they accidentally eat something that is going to produce galactose in their body, most of the time their body is already producing more galactose than what they accidentally intaked. So my daughter, for instance, must have a lot of galactose in her body that it's just making on its own because she has so many complications. And there's nothing we can do about it. Once that galactose is made, once it's in the body, there's nothing any doctor outside of her body can do. We can just watch for the symptoms, try to treat the symptoms. Our personal experience has been that we'll be in therapy and we'll be seeing, we call it a roller coaster. We see just so much upward movement, and then all of a sudden she'll slide back, like she's been re-injured. And a lot of that is just because that galactose is ongoing in her body all the time. So we need a treatment to bring that galactose down that will bring down the poisons that it creates, so that her body can continue the upward movement and grow like a normal child would.
Hello, I'm Judy Fridovich-Keil. I'm a professor in the Department of Human Genetics in the School of Medicine at Emory University, which is in Atlanta, Georgia.
Yes, hello. Hi, I'm Jerry Berry. I'm a professor at Harvard Medical School. I'm also the director for metabolism or biochemical genetics at the Boston Children's Hospital. And I'm also the director for the biochemical genetics training program for the Harvard Medical School.
Thank you so much for this opportunity to speak with members of the galactosemia community and hopefully the broader community. Jerry and I are really delighted to be able to give a little bit of a background overview of galactosemia. Galactosemia is a family of disorders resulting from impaired ability to metabolize galactose. So the word galactosemia actually means excess galactose in the blood. And how does that happen? Well, galactose gets into the body in either of two ways. Either it comes in through the diet, so that's the faucet dripping into the tank on the left-hand side, but our bodies can also make galactose. Every single cell in your body, as far as we know, can make galactose, and so that's the little faucet dripping into the tank from the right. In terms of dietary galactose, the main place we get dietary galactose is from dairy milk. So human breast milk has about 19% of calories from galactose, so that's a lot. Cow's milk has about 15% of calories from galactose, that's also a lot. And your body can metabolize the lactose in milk to galactose and glucose, and so that adds to the tank. How does galactose leave the tank? Well, through a process that we call metabolism. And on the next slide, we will get a little into the detail about galactose metabolism. So, Jerry?
Well, it's a real pleasure to be here today and to participate in this important event. So how is galactose normally metabolized? It's metabolized in the body through a special pathway called the Jaguar pathway. Type 1 galactosemia is the disorder that we most commonly talk about. It is due to GALT deficiency. And GALT is the short name for a complicated enzyme name called the galactose 1-phosphate uridyl transferase. Galactose comes into the body, and then it has to undergo a sequence of chemical reactions. The first one involves the enzyme galactokinase. And this goes by the abbreviation of GALK. In this enzyme reaction, the galactose is converted to galactose 1-phosphate. Now, the next reaction that should happen is the conversion of the galactose 1-phosphate to UDP galactose. And that's what is missing in classic galactosemia. As you can see above that, the arrow that's pointing in both directions, it says galactose 1-phosphate uridyl transferase. So all of the bad things that happen in type 1 galactosemia due to the GALT deficiency are all because of this simple inability to convert that galactose 1-phosphate to UDP galactose. The UDP galactose that's formed can then be transformed back again into a UDP glucose. And the UDP glucose is in fact then something that needs to interact with the galactose 1-phosphate to produce the UDP gal. So this is a cycle, so to speak. The conversion of the UDP galactose to the UDP glucose happens because of the enzyme called GALA. So this is the Loire pathway. Type 1 galactosemia or GALT deficiency can be subdivided for simplicity's sake into three forms. Classic galactosemia, which has less than 1% residual GALT activity. The clinical variant form of galactosemia, which is associated with 1 to 10% GALT residual activity, and the Duarte or biochemical variant form of galactosemia, and is associated with, on average, 25% GALT activity. Classic galactosemia is an autosomal recessive disorder. This means that both mother and father are carriers for the mutation. They have one gene or allele that works well, and then another one that is the galactosemic one. Each parent with any conception has a 50% chance of donating the bad gene to the baby. And if both do, then that will result in a baby that has 2 copies of the genes that don't work. But please recognize that with each conception, there's a quarter chance that the patient will have the disease, but there's a 75% chance that the baby will not have it. There's a 50% chance that the baby would be a carrier, and then a 25% chance that the baby would have 2 copies that is normal. Type 2 galactosemia is GALT deficiency, which is very rare, and type 3 galactosemia, which is GAL deficiency and is subdivided into 3 forms.
Not every case of galactosemia results from GALT deficiency. That's what Jerry just explained in looking at the Loire pathway. There are 2 other enzymes, that the GAL-K and the GAL-E, and there are human beings born who have problems with those enzymes. Most of our time for the rest of today, though, will be spent talking about GAL-T deficiency. And then even within GAL-T deficiencies, they're not all the same, and it's extremely important to keep that in mind. We are going to be talking about classic galactosemia, and this graph, so these are just box and whisker plots from a paper that we published a long time ago. And these are actual clinical lab results for individuals looking at the GALT activity in their red blood cells. And what you can see is that, see the red arrow pointing at the CG. So there we have 22 individuals, and you can see that all of them have almost undetectable to undetectable GALT activity. The folks who are listed as NN, so those are the basically normal controls. There's a broad range, but they all have really nice GALT activity, and you can see the different categories. But for the rest of this session, we will be talking about true classic galactosemia, which is the folks who really have no to almost no residual activity. And one of the really blessings of the second part of the 20th century was the initiation of newborn screening. To briefly summarize, when the baby is born, they collect some drops of blood, usually from the child's heel prick. A little image of that slide showing what's called a Guthrie card after Bob Guthrie, who started this program. It's important to recognize that newborn screening, although it is federally mandated, each state gets to decide for themselves how they're going to do it. And so although some states started in the early to mid 60s testing every newborn to see if they had galactosemia, there were some states that did not add it to their panel until 2004. It's called newborn screening because it is intended to be fast, to be effective, and to be economical because they're doing it on lots and lots of babies. And they set thresholds so that hopefully they will never miss a true positive, and it means they have a lot of false positives. So if a child in the state lab is identified as having undetectable GALT activity, the pediatrician is notified, the family is notified, and is told, stop breastfeeding that baby, put them on a low galactose formula. Typically that's soy, but there are other options as well. And quickly bring the baby back in. We need to do follow-up testing. And follow-up testing generally means they're going to collect a fresh blood sample, and it's going to go to a lab that is going to do very quantitative tests, looking for a number of different things. They're going to do a very quantitative test for GALT activity, and they're going to ask, is it undetectable? Is it 25% nor, what is the activity? They will get out a number, and that will be very informative. They also will generally look at metabolites. So galactose 1-phosphate is typically a metabolite that is looked at, but they could also look at others. Anyway, so generally to actually diagnose galactosemia, you need to have a quantitative assay looking at enzyme activity, and that's usually done from red blood cells. And they typically also want to look at the metabolites. Oftentimes, there is also genetic testing, so they will isolate some DNA from blood and look for mutations. Sometimes they look for a panel of common mutations. Sometimes they actually sequence the GALT gene to look for rare mutations. Again, it's done differently in different places. So that is diagnostic testing. So here we're looking at a graph. We're asking, what is the prevalence of classic galactosemia? And really, one of the best ways to identify prevalence of a condition in a population is if you have truly population newborn screening or population screening. And so here you can see a bunch of states listed by their two-letter code on the bottom, and the number of years of data that I was able to get from them. And that's plotted. In general, for pretty much all the states, the prevalence is about 1 in 50,000 screened births.
Several decades ago, most physicians felt that classic galactosemia was treatable, and the only thing that one needed to do was to have the newborn baby stay away from breast milk or a formula that has galactose in it, or something that's associated with dairy products, and the baby fine. However, what we have learned in the past 25 to 30 years is that, yes, the positive newborn screen enables an immediate dietary restriction of galactose, but there are other problems that still exist. Despite early diagnosis and lifelong dietary restriction of galactose, many infants with classic galactosemia grow to experience a constellation of long-term developmental problems. And while the newborn screening is wonderful because it allows for intervention right away in the first few days of life, it allows the jaundice or vomiting or diarrhea or failure to thrive and cataracts, liver enlargement to disappear, as well as these most feared complications of E. coli sepsis. It does all that, but what it can't do is prevent the vast majority of patients with classic galactosemia of having a delay in speech and or a speech defect, or having a delay in their development, or having problems with learning in school, or for almost all of the females to have normal ovarian function. Many of those individuals are unable to have to give birth to a baby. Also, there are a few, thankfully, usually under 50% of individuals in different studies that actually have more severe complications that involve the nervous system and can result in abnormal movements or even an inability to walk without assistance.
So again, these are long-term complications that occur no matter how early the baby was switched to a low galactose formula. So even if the baby never drank a drop of milk and very, very rigorously restricted galactose from the diet, we see a much higher prevalence of these complications in people with galactosemia than in, for instance, their unaffected sibling. So again, these are actual data from people who participate in one of our studies. Starting on the left, you can see the outcome of speech, and here, because people with galactosemia live all over the place, and we did not have the ability to test them all, we asked, well, who has received speech therapy? And we picked an age period where it was likely not going to be preventative, but actually responsive to a problem with speech. And so you can see that we have the patients. These are people with classic galactosemia in the left bar, and controls. So those are unaffected siblings in the right bar. And some of the controls needed speech therapy, but not many. And about half or even more than half of the people with classic galactosemia received speech therapy. And here we're looking at receipt of other special educational services. So typically these were children who were struggling with academic subjects in school, who were receiving some kind of special educational help. And depending on the school system, exactly what the help was varied from child to child. Again, you can see that the kids who do not have classic galactosemia, some of them, but not many of them, needed special help. But more than half of the kids with classic galactosemia needed special services. Then we're looking at something called prepubertal growth delay. So what that means is that if you looked at the heights of the parents and you calculated what the predicted height of the child would be at a particular age, and you looked at the actual height of the child at that age, were they where you expected them to be? Were they shorter than you expected them to be, or were they taller than you expected them to be? And that's the Z-score. And I think you can see that for the controls, that median is right on 0, which is they were where you expected them to be. Now that's the median. Of course, there are always some kids who are a little taller or shorter than you expected. If you look at the patients, I think you can see that the median is below. That the median is the horizontal bar in the middle of the box. So again, there's a broad range, and there are some very tall kids with classic galactosemia, but as a group, they were shorter than expected. And this was prepubertal. They generally tend to have a slightly later puberty. They keep growing, and they do catch up usually by the time they're adults. The next graph looks at adaptive behaviors. So these are the behaviors that people do to get through their, everyday lives, taking care of themselves, interacting with other people, interacting with the environment. And here we used a standard and well known study called the Adaptive Behaviors Assessment System, version 3. And again, you can see that the controls, the median for the controls was actually a little bit above 100. 100 would have been considered average. So we have some very well adapted families, I guess. And the patients, again, there's a broad range, and some of them are doing great. Some of them are really struggling. Most are somewhere in between, but again, the median is substantially below the median for the controls. The next set over is looking at scholastic achievement using standardized tests that are given in schools. Many school systems give standardized tests in math and in language arts, and children are assessed and scored as to whether they are achieving at or above grade level or below grade level in each of these subjects, math and language arts. And I think you can see that for the controls, 94% of them were achieving at or above grade level in both subjects, and 6% of them were at or above in one subject but below in the other. For the siblings with classic galactosemia who were raised in the same households, going to the same school systems, living in the same geography, you can see that it's split almost a third in terms of, again, some of them are doing great, some of them are struggling in both subjects, and some of them are in between. So the last set of graphs on the right-hand side refers to the motor control issues that Jerry was talking about. Now, there can be motor control issues that affect gross motor skills or fine motor. Here, we actually used a digital system that assessed fine motor control with the hand. And so what you can see is that the lighter the color of the bar, basically the better their fine motor control was. So for the controls, some of them had a little bit of trouble, but most of them were doing just fine. And for the patients, you can see that, again, about half of them had no problems with the task we gave them, but the other half had either a little bit of trouble or a lot of trouble with the task. And so that is just more evidence that we really have not cured this disease. So there's a lot of variability, and that is one of the challenges, I think, for families when they're looking at their beautiful baby, saying, is my baby going to have problems with speech or problems with, name your outcome? At this point, it is very difficult to know. Identifying it early by newborn screening is wonderful, and it is life-saving. And switching the diet, again, is life-saving, but it is not giving every member of the galactosemia community a kind of outcome that I think we would want them to have, that their unaffected siblings are enjoying. And so that brings us to the last slide, where we just stress that this is a disease, this is a community that really needs and deserves better interventions. It is very clear that dietary restriction resolves the acute symptoms, or even better, prevents the acute symptoms, but does not prevent the long-term complications. So that's really where we're focusing attention now, is on the long-term complications. And the challenge is that the mechanism really is not understood. And I don't just mean Jerry and I don't understand it, we don't, but I don't think anybody really understands how to connect the dots at this point between, well, we know this enzyme is missing, we can identify the mutations, we can look at metabolites, so we know that galactose builds up, we know that galactose 1-phosphate builds up, we know that galactitol builds up. In an animal model, what we've seen is that the metabolites that accumulate are even in different proportions in different tissues, suggesting that the mechanism of pathophysiology may be different in different tissues. So at this point, this is our group challenge. Many of us are working very hard trying to find better interventions to help prevent and hopefully even modify or minimize long-term complications. And we don't know exactly what the best way to do this is going to be. Many of us are trying different options, and we dearly, dearly hope that in our lifetimes, hopefully in the near future, we will have better options for families with classic galactosemia. So thank you.
My name is May Tobar, and I am the Director of Patient Advocacy at Jaguar Gene Therapy. The Jaguar Patient Advocacy team serves as the primary contact between Jaguar and the patient community. And we've taken that a bit of a step further here at Jaguar, and we've worked very closely with the Galactosemia Foundation and other patient communities to develop a unique advocacy philosophy for our company. And that is to advocate boldly and care fiercely. And in order to do that, what we've done is we've developed a set of principles that we abide by, not just us on the advocacy team, but everybody here at Jaguar. And that first one is the collaboration with family and patient advocacy organizations. I have had the pleasure of working with Britt and Nicole and the Galactosemia Foundation literally since the first day on the job here at Jaguar, and making sure that we're identifying those shared goals and making sure that we can advance them forward. Another guiding principle is that we recognize that Britt and Nicole and these families that you're about to hear from, they're the experts. We have to actively listen to them and learn from their perspectives and experiences. And we use those perspectives and experiences and everything that we learn from our partners in the community to inform our clinical trial programs. There's absolutely no way that we could achieve our mission at Jaguar to accelerate breakthroughs in gene therapies for patients living with severe genetic diseases like galactosemia without the collaboration, the partnership, and the learnings that we receive from the Galactosemia Foundation and from the family. It is my absolute pleasure to introduce you to the next 3 families that you'll be hearing from. I have had the honor of working with all of these families over the past few months, and I think that you'll be able to learn a lot from their experiences, as we already have. You'll be hearing from Allison and her son Brooks, who is 2. You'll be hearing from Megan and her daughter Ava, who's 7. And then you'll be hearing from DJ, who is living with galactosemia, and his dad, Dave. So without further ado, I would love to turn it over to Allison.
Hi, my name's Allison Woodfin. My husband and I have Brooks Woodfin, who is a 2-year-old with classic galactosemia. And he has changed our life so much in these 2 years that he's been here. He was born on a Thursday, and he just seems like a perfect little infant baby. We went in just to establish care with our pediatrician. They start taking his temperature, and it's 94 degrees. This can be a sign of infection. It can be a sign of virus or some other issue. He is still super jaundiced, so we're gonna go ahead and send you to the local children's hospital. They're probably gonna do a spinal tap. There was all of these things kind of thrown at us, and we weren't really sure what was going on. And they told us that his liver panel was coming back, and it was not good. It was extremely out of range. They're doing head ultrasounds, and they're testing his glucose because his blood sugar now is in the 20s and the 10s. They're trying to take blood samples, and he's just bleeding. It's not stopping. His blood's not clotting. The doctor said, hey, we're gonna have to transport you downtown. So they got us ready. We signed consent forms, and I looked back on those consent forms about a month ago. And under the reason for transfer, it was saying like liver issues, all of his issues. And then it said issues if not transferred. And underneath that, it said death. They asked me, hey, do you want to hold him before we go ahead and intubate him? And I said, of course, I want to hold him. So I'm sitting there, a new mom just gave birth not even a week ago, holding him, and he's screaming bloody murder. He's screaming bloody murder, and I'm trying to rock him and comfort him. And finally, I just said, okay, you can have him. I know y'all need to do what you need to do. And I walked out. So a geneticist came in, and he said, hey, we got their newborn screening results back, and they're saying it's galactosemia. He ended up getting a clot in his artery in his groin from that line that was placed there. And that made it to where we could not access that port. And he also lost access to both of his other IVs that they had placed. So at 10 p.m., we had no access to Brooks. That made us realize that this could be it. This could be the last night. They had Brooks with a tourniquet around his head, trying to find veins. They had it on his foot. They were looking anywhere for a vein to place an IV in. And at like 7 or 8 o'clock the next morning, they were finally able to place him. So finally, when those results start coming back, and they're getting better, and they're getting better, and they're getting better, we're breathing a sigh of relief. But they said, as long as he gets through this, the only thing you have to do is diet. That's it. You have to do the diet, and he's fine. Right now, he sees his vision doctor, he sees his genetic specialist, he sees his liver doctor once a year now, thankfully. But he has all these specialties. He sees neurologists. A lot of people think that as long as you eliminate the galactose, that you're good. That's definitely not the case. His body actually naturally produces it. All of our bodies naturally produce it. And unfortunately, he doesn't have the ability to break it down. Right now, having diet as a treatment, that's not a treatment. That's the bare minimum for us. Because it's preventing massive issues in death, but it's not preventing all of these other issues that we have to play whack-a-mole with and, you know, take care of them as they come. It's not getting to the root of the problem.
Hi, my name is Megan Lilia. I am a mom to a 7-year-old daughter with classic galactosemia. Ava is a girly girl. She likes all things glitter, sparkle, loves unicorns, and most of all, her cat Cookie. School is a struggle for Ava. Learning is hard, and it's a struggle. Right now, she's in 1st grade. She receives services at school, special education services, adapted Phy-Ed, occupational therapy, and speech therapy. She is on a individualized education plan and gets daily assistance in school. Yeah, I think when my daughter was born, I learned about all the things that could happen, and I hoped and prayed that they wouldn't happen. I got her early intervention services. I'm an occupational therapist myself. So with doing all of that, I was hoping that she wouldn't get those impairments. As she's gotten older, they become more and more present. And sometimes it just feels like it just doesn't stop. There's one more thing, and now there's another thing wrong, and now there's this thing wrong. And unfortunately, I don't think we've reached the end of that yet. So I am preparing myself, but I compare it to grief. It comes in stages. You know, you have this hope that your kid won't have that, and then as they age and things get worse, that grief comes because all of a sudden they can't skip. Okay, that's all right. Well, now they can't ride a bike. Now their handwriting is hard. Now learning is hard. Now they can't learn how to read. You know, so all these things I hope my daughter can get to someday, but right now she's struggling. I have lots of concerns about Ava's future. I worry about her cognition and her vulnerability. In lots of different ways, but mostly cognitive, because I don't feel she has the same reasoning and insight as kids her age. And as she becomes an adult, if I'm not there, I worry about that. I also worry about basic life skills, being able to pay your bills, have a job, show up on time, keep things organized. For females, galactosemia also can affect fertility, which is another concern. My daughter is 7 and she has baby dolls, and she'll often tell me about how she's going to be a mom someday. And it's very difficult to hear that, knowing what I know, that her fertility can be affected, but obviously she's 7 and doesn't understand that yet. I believe that we need to advocate for this disease. It is more than just a dietary restriction. Galactosemia has affected just about every part of our lives and my daughter's life. And I want to advocate for her and for others.
My name is David or DJ, and my age is 28 years old. I like to go to the desert and remote control cars.
What do you want people to know about you?
I have this one disabled too sad. Metabolic disorder.
What is that metabolic disorder called?
Galactosemia.
What does having galactosemia mean?
I cannot have anything with milk products or cheese.
Mm-hmm. So are there any other ways that galactosemia affects you?
Hard to talk to people.
Hi, I'm David Trainer. I am the parent of a classical galactosemic. As DJ reached puberty, we started noticing some other things that were going on in his life. That's when seizures started. His tremors became a little bit more prevalent. So we were looking for answers as to why some of these things were triggered and what we needed to do about them. The seizures were absent seizures, where for 30 seconds, DJ would just sit there with a blank look on his face, and then when he'd come back, his head would be tingly. So we started looking for answers, and the neurologist sent us to get an MRI and explained it to us this way. There's a little bit of white matter, gray matter on his brain, and this is affecting his brain in the way that it communicates with itself. It's kind of limited communication here and there. So that was a really harsh realization that not much is going to change, because this white matter, the gray matter that's showing up in the MRI is never going to go away. But is there a fix to this? And the reasonable answer was no. There's no fix to it. But it could get worse, and that's what the doctor was telling us. DJ has been a classical galactosemic young man, little boy, infant since 9 days of life. He's overcome, surpassed, proven people wrong, and just trudged on through life as if there was no issues to be dealt with. He's an incredible young man, and he keeps that up daily with a smile on his face all the time. And he has this he has an absolute love of life. If there was a treatment that we could have provided for DJ at the 9th day of his life, when they said your son has classical galactosemia, we can offer this product so he doesn't have any of the outcomes that are normal in galactosemic patients. If that was a choice at that time, it wouldn't have been a choice. It would have been, let's get this done.
Hello, my name is Joe Nolan, and I'm the CEO of Jaguar Gene Therapy. It's our mission at Jaguar to accelerate breakthroughs in gene therapy for those living with severe genetic diseases. And for individuals with galactosemia and those caring for them, we know the journey toward availability of treatment options has been long overdue, and we recognize the urgent need to change this. We are honored to be a partner with the Galactosemia Foundation and the galactosemia community to help build awareness for type 1 galactosemia and the impact it has on patients, families, and their caregivers. Type 1 galactosemia, it's essential that we treat this disease as absolute early as possible. It can be life-threatening for newborns and can cause lifelong issues with cognition, neurological, including speech, fertility complications. And despite the adherence to a diet, which is the current standard of care, we realize that the long-term implications of this disease is real, and we're here to try and get a treatment to market to help these patients. At Jaguar, we're working hard to develop a one-time gene therapy to address the root cause of type 1 galactosemia. We're doing this by delivering a functional GALT gene. It's early days, we have a lot of work ahead of us, but we believe this treatment option could have a profound effect on the lives of those living with type 1 galactosemia and their families. For more information on galactosemia, I encourage you to visit the Galactosemia Foundation. I'd like to thank you for joining us all today, and I'd like to thank for our partnerships with Advocacy, especially at the Galactosemia Foundation, both Nicole and Britt. Also, our key thought leaders and experts, Dr. Fridovich-Keil and Dr. Berry, and our patients and our parents, both Allison and Megan, as well as Dave and DJ.
So I was asked to talk about about what is sort of the best window of opportunity for intervention. And the true answer is that no one really knows, but I can make some educated guesses. So the question really stems from asking, well, when does the damage, and whatever that means, when in development does a child, a baby, who has classic galactosemia, at what point is there a difference between what's happening in their body and what's happening in the body of a child who doesn't have classic galactosemia? We know that there are metabolic differences. So, for instance, if you looked at the amniotic fluid of a baby before they were born, and the baby had galactosemia, you would see differences. You could detect higher metabolite levels in utero for a child with classic galactosemia than without. But we know that the acute symptoms don't start until the baby sees a large, dietary load of galactose. So we're really asking, though, about long-term complications. And what gives me hope, so the short answer is, I think the earlier we can intervene, the better. Okay, so I think intervening in a baby, I think preventing problems is usually easier than resolving them or than reversing them. Now, I say that based on very general knowledge, since we don't truly understand the mechanisms that lead to speech problems, motor problems, cognitive problems, ovarian problems, and so on in galactosemia. Some of them might be reversible. And so I think it is certainly, I am hopeful that if we can intervene very early, we can make a big difference. And if we can intervene sometime later, we can still help, whether or not we will be able to make as much of a difference in as many of the outcomes. I don't know. That's something that we will have to learn as we go.
Yeah, so when we decided to form Jaguar Gene Therapy, we're very fortunate to have a tremendous team of experts and experience in the field. And we were fortunate enough to get another gene therapy to market. And that experience in that disease state really changed all of our employee base. And was such a spectacular feeling to help that community that the chance to do it over again is really why we formed Jaguar. It's really almost an obligation that we knew we had because we've been able to do it once, and the chance to do it over again is really why we're all here today. We're focusing on type 1 galactosemia because we believe it's another one of those disease states where the families, the patients, and the caregivers really deserve that chance to have something that treats the root cause very early on in a newborn's life and can really change the entire trajectory of that person's life, their family, and their caregivers. Our goal right now is to be first in human studies in the first part of 2023. That's after we complete all our preclinical studies, which are going very well. And we're highly encouraged by the results we've seen in animal studies. So again, we meet with the FDA and we should have first in human trials up and running in the first part of 2023.
It is absolutely essential for companies like Jaguar Gene Therapy to work with patient advocacy groups for a variety of reasons. I think First and foremost, they are the experts in their disease state. They live with the disease often every day. They're caring for somebody with the disease every day. They're completely immersed in the community and all of the nuances of that community. So while we can sit in our offices, right, and read as much as we can possibly read and absorb all of the research that we can absorb, there's no way for us to understand that true human experience without building meaningful connections with these organizations and the community and the people who live it every single day. So for example, learning what we can learn from these families and learning about their human experiences and perspectives, it's not only helpful for us to be able to understand what this disease truly is like and the actual burden of disease and the caregiver burden, what it means for daily life and how it impacts everyday activities, but it also ultimately can shape our clinical trials. It can tell us what endpoints we want to make sure that we're measuring so that we know that it's going to be meaningful for the families who hopefully will eventually receive a product. It also helps to make sure that we're designing these clinical trials in a way that people are actually going to be able to participate in, right? So making sure that we understand any sort of transportation challenges, making sure that we're providing some activities for these children who might be involved with these clinical trials while they're on the clinical trial site. So while we have a really important job to do to accelerate these breakthroughs in gene therapy for patients living with severe genetic diseases, we literally could not do it without the help and the support of the community.